Well, thanks for everybody for coming and everybody that's on the Zoom call. This is an exciting day for our group. We've missed out on having the JOA fellows because of COVID for a while now, and they've returned. And I just wanted to give a little bit background on the JOA AOA fellowship because I think a number of the faculty here have done it, and I think it's a great experience for some of our junior faculty to apply and do this fellowship. What it really is collaborative exchange between the two countries and academic institutions of the two countries. And so the applicants are selected based on their leadership skills, some of the research they've done, and their personalities during the interview process. And really, it's a 4-week tour. We alternate between the two countries. So 1 year it'll be in Japan, 1 year it'll be in the US. Most of the time, they're visiting about 5 to 7 centers. And we're lucky this year to have 5 Japanese surgeons with us here. And really, I want to encourage the assistant faculties to apply. I also want to acknowledge the tremendous amount of effort in organizing this with Pamela and Tyler really doing the lion's share of work. And then the faculty helping support not only funding, but also being available and showing a good time to the visiting fellows. And Dr. Unar Nork, I heard dinner was fantastic last night. Went a little late. Everybody looked a little tired this morning, but I don't expect anything less from the Narks. So we actually have a long history of having our faculty go to Japan for this specific fellowship. The fellowship is about 31 years old, 2 years after it started. I think Bruce went to Japan. Sean went about 10 years after that. And then I went in 2016, and then Dr. Clavino went in 2018. So we have this longstanding tradition, and we want to continue that with some of our younger faculty, hopefully in the near future. So to present the fellows, our first talk will be on augmented reality technology and total joint arthroplasty. This will be done by Dr. Tsukada, who's from Mito. Second talk will be clinical results of PAO with structural allograft for severe hip dysplasia. This will be done by Dr. Fujii. The third talk will be indications and limitations of laminoplasty, a multi-centered study from a nationwide Japanese institution. And this is Dr. Nagoshi from Tokyo. Next talk will be on advantages and disadvantages in minimally invasive spine surgery by Dr. Oshima from Tokyo. And then the last talk will be on blood supply in the forefoot by Dr. Tonogai, which he will be talking to us based on his experience at his home institution at, I don't know if I'm pronouncing this right, Takamatsu Red Cross Hospital. Is that right? Okay, great. All right. With that, we'll go ahead and start. For the folks that are on Zoom, if you could text me or Dr. Chansky any questions you may have, we can bring all the questions up at the end.
Thank you for your kind introduction, Dr. Body. I'm Tsukada from Mito City. It is a great honor for us to present here. Thank you very much, everyone. My presentation today is about the navigation system for joint arthroplasty using surgeons on smartphone. This is an outline of my presentation. Firstly, I'll provide you with an overview of augmented reality or AR. Next, I will talk about the tibial bone resection using AR-assisted navigation system. Lastly, I will discuss the femoral bone resection using AR-assisted system. First, I'd like to tell you what augmented reality or AR is. AR is an imaging technology that utilizes computers to make things that are not really there appear to be there. For example, a Japanese famous mobile game, Pokemon Go, utilizes the smartphone technology to make monsters that are not really there appear to be there through the smartphone. We utilize this AR technology for the hip or knee arthroplasty. Please see the right picture. When you see the QR code in real world through the smartphone, you can view the virtual image of a patient's pelvis in all directions. We have applied the AR technology to navigation system for total hip arthroplasty first and reported its clinical effectiveness. Please see the video. You can, yes, the AR assist system enable us to visualize the virtual pelvis superimposed on the patient. In addition to the virtual pelvis, you can see the pelvic plane as green grid and inclination and anteversion angles of acetabular. The top placement using AR assist navigation system. The smartphone is placed in the stabilized case and attached to the cup impactor. Right, video shows the smartphone screen. You can see the pelvic plane and the slide cannot work well. You can see the green pelvic plane as green grid, and you can see the inclination and anteversion angle. But pop up to the screen, like here. Open. And this slide camera works well. Please, yeah. Okay, thank you very much. If you have the pre-operative CT data, the AR technology enables you to visualize vesicles and nerves superimposed on the patient. Please see the video. Smartphone track the QR code, you can see the vesicles and nerves superimposed on the patient or patient body. You are in touch. Our research about the augmented reality was featured in the editor's spotlight at Take 5 of clinical orthopedics and related research in 2020. Thank you very much. Next, I'd like to discuss the main focus of my presentation, which is a navigation system for knee arthroplasty. We have developed a navigation system for knee arthroplasty using AR navigation. We measure how surgeon gets the information during tibial cutting. A QR code marker is fixed to the proximal tibia. The smartphone is placed in sterilized case. You can see the cutting angle of proximal tibia, and you can also see the mechanical post of the patient. This video shows how to register the mechanical axis of tibia. First, use the QR code and through the smartphone camera, and next you touch bone landmarks. Use a pointer that have QR code. Knee center, lateral malleolus, and medial malleolus. Please see the green line. That line is the patient.
Sure. Yeah, it's like how it is.
Yes. And you can touch that as a body landmark and to see the anterior posterior axis of tibia and upper right.
Yeah.
It's from lateral and medial tibia.
Just so several of them catching a flight to Houston and flying over that.
Is it body landmarks in all directions in real time. These pictures show how surgeon gets information during femoral bone cutting. A QR code marker is placed on the stable side. Please note that marker is not fixed to the patient's body directly. The smartphone is attached. The smartphone is attached to the cutting jig, and you can see the mechanical axis of femur and center of the femoral axis superimposed on the patient. This video shows how to register the femoral head center and mechanical axis of femur during surgery. Measure insert into the center of femur. And attach the jig with slot. That you are code of the person, the slot of spring, pressure, rotated, patient joint. That's a registration. Next of all, you can see the femoral head center, mechanical axis, and cutting angle, including various angle and flexion, extension, and during this angle, surgeon fix the cutting jig at the distance. We believe the AR assist system we developed has some merits, but there has been no study to assess the accuracy of AR-assisted navigation system. So the aim of this study was to investigate the accuracy of AR-assisted navigation system. Our study consists of two parts. First, in experimental study, we cut tensile bones with AR-assisted navigation system and took CT scan. Second, in clinical study, we performed 72 TKAs with and without AR-assisted navigation system, and after surgery, we took standing long leg X-ray. In all TKAs, we aim to reject both distal femur and proximal tibial perpendicular to the mechanical axis in the corner plane. Result: in experimental study, the mean errors of bone cutting in femoral side were 0.8 degree in corner plane and 0.6 degree in sagittal plane. In tibial side, the mean errors were 0.5 degree in corner plane and 0.8 degree in sagittal plane, respectively. In clinical study, the mean errors in femoral side were 1.1 degree in navigation group and 2.2 degree in intermediate load conventional method. The difference was statistically significant. And in tibial side, the mean errors were 1.3 degrees in navigation group and 1.3 degrees extramedullary load. Conventional navigation systems for knee arthroplasties are undoubtedly useful, but several disadvantages have been pointed out. First, the conventional navigation systems are expensive. Several studies conclude the most important problem of the conventional navigation system is a lack of cost effectiveness. And second, surgeons must take their eyes off of the operating field to view the navigation screen. Finally, the conventional navigation system may be unsuitable to train residents because some surgical procedures are different between the TK with and without navigation system. We believe that our AR-assisted navigation system has some merits, but the cost to use the AR-assisted navigation system is very low because it works present on smartphone and some QR code markers. The second, and surgeons can use navigation system with viewing surgical field, with viewing smartphone screen. And we believe that AR-assisted navigation system can be used for educational tools. We believe that AR-assisted navigation system can be used for the educational tool. For example, express and experienced surgeon can share information about the important bony landmark during surgery. Please see the video. Surgeon and assistant can share information and such is good, but another advantage of the AR navigation system is that you can visually confirm the registration point. You can easily recognize the registration point is correct or not. In the picture, registration point of the medial malleolus is wrong. Although the AR navigation system has several merits, the accuracy has not been investigated. We believe that AR-assisted navigation system's accuracy is acceptable. Finally, we have already developed navigation systems for TAJ and TKA, and in the AR-assisted system, additional function can be incorporated only by adding program to the application. So the AR-assisted navigation system is easily adapted for other surgical procedures. I bring one example. Video shows the AR navigation for intermediate nail procedure for femoral shaft fracture. But you register some grounding. It's growing barcodes so smartphone. Please see the video and you can fit the intermediate nail through the patient form and the placement is correct or not. The rotational angle between proximal and distal fragments are shown in the smartphone screen. Conclusion, the AR-assisted navigation system may provide an acceptable accuracy of the navigation system. And the AR-assisted navigation system may be low-cost navigation system, and it has the capability to adapt to other surgeries. Thank you very much.
Good morning, everyone. My name is Masanori Fujii from Saga University. My talk is about the result of PAO in Japanese style with structural bone allografts for severe hip dysplasia. So I am from Saga University. This is Saga Prefecture. The Saga Prefecture is known for some place and a beautiful location. And this is our university hospital. I am originally from Kyushu University, where former professors, Professor Nishio and Sugioka, developed cerebral hip osteotomy. So my talk is about the PAO. The PAO is an established procedure to treat patients with hip dysplasia. In Western countries, the PAO means GANS PAO, but in our university, we perform a specific type of PAO. It is called transpositional osteotomy of the vertebra, the Professor Nishio reported in 1956. It is characterized by lateral approach and spherical osteotomy. We recently updated the long-term result of PAO. And this study showed the long-term durability of PAO with a survival rate of 96% at 10 years and 80% at 20 years. Our recent work showed that 75% had no or minimal pain and 76% had high satisfaction after POA. The 66% met both criteria and have achieved satisfactory status at the TOA. We also studied the biomechanical effects of TOA. We performed the finite element analysis on 47 patients who underwent TOA. And this study showed that TOA normalized joint contact pressure in 65% of cases. However, the joint contact pressure was still high in patients with severe hip dysplasia. The PAO for severe hip dysplasia is a challenge for hip surgeons. The severe dysplasia has limited weight-bearing area, and it is difficult to achieve proper reorientation and anatomical reduction. So clinically, severe hip dysplasia has been reported as the predictor for outcome of PAO. To overcome this problem, at Saga University, Professor Tonogai and Masanori modified TOA to use bone allograft with TOA. A larger acetabular correction creates a gap between the ilium and the acetabular fragment, into which structure allograft obtained from the sterilized femoral head during the THA. The bone allograft has several advantages over autograft. It has no donor site mobility or limit on quantity, and it further enhances the acetabular correction and enable anatomical reduction. So the purpose of that study was to clarify the midterm results of TOA combined with structural bone allograft for severe hip dysplasia. We defined the severe hip dysplasia as lateral angle less than 0 degree, and the median follow-up term was 10 years. Nearly 700 patients had undergone TOA at Stockholm University today, and TOA with bone allograft for severe hip dysplasia was performed on 85 patients. In total, this study included 64 patients. The median age was 27 years, and median follow-up term was 10 years. This is the surgical procedure through lateral trochanteric approach. We performed a spherical osteotomy using the curved scissor. The larger acetabular correction creates a gap, and this is the allograft. We inserted the allograft into the gap. Then the allograft and the acetabular fragment were fixed to the pelvis using 2 or 3 cortical screws. The absorbable screw was used in this case. And the remaining gap was filled with moisturized allograft. The clinical outcome was measured using modified Harris-Hip score, and radiographic parameters were measured on brain radiograph. And the joint survival rate was estimated with clinical grade 3 or aspiratic arthroplasty as the endpoint. These are radiographic parameters: the lateral angle, acetabular index, and the sharp angle, and acetabular head index was measured for coverage on the coronal plane, and acetabular wall index was measured as indicators of acetabular coverage on the sagittal plane. The modified Harris score was improved from 67 point to 96 point at the final follow-up. The complication occurred 9.2%, and among them, the allograft resorption was occurred into hip. The absorbable screw was used in these cases. Radiographic parameters show significant improvement with a median lateral angle correction of more than 40 degrees. As a result, the coronal acetabular correction normalized in more than 90% of hips. The overall joint survival rate was 95% at 10 years and 80% at 15 years. According to the tennis grade, 15 years survival rate remained at 100% for hip with grade 0 or 1, while that of tennis grade 3 hips dropped to 52% at 15 years. The multivariate analysis showed that the pre-operative tennis grade 2 as an independent risk factor for failure. There has been 6 studies on PAO for severe hip dysplasia. The OA progression rate varies between studies, but the OA progression rate of this study, 9.2%, was within the reported range. According to the acebra correction, our study showed a substantial acebra correction of 47 degrees, which is comparable to previous studies. The allografts have advantage, but it also have disadvantages, including reduced osteogenicity and osteoconductivity, disease transmission, and infection. However, in this study, 97% have achieved successful fusion. 2 cases with absorbable screw had allograft resorption. So we consider the cause of resorption is the loss of initial fixations. We routinely use metal solid screw. No deep infection related to allograft was not observed in the study. This is conclusion. The structural allograft in conjunction with TOA is a viable surgical option for correcting severe hip dysplasia in young patients with advanced OA. The midterm outcome were encouraging. However, further follow-up studies are warranted to confirm its durability and long-term effectiveness. Thank you for your attention.
Okay, thank you. My name is Narihito Nagoshi. Before my talk, I really appreciate the so organized program and the work done. We enjoyed a lot. So, my talk is laminoplasty, but before talking about that, I want to introduce my hospital. I'm from Keio University. It is located at the center of Tokyo. And we have relatively new hospital from 2018 with the outpatient clinic space is like hotel, and we have a wider board and a beautiful operation room. Anyway, do you know the Yakuza? Yakuza is a Japanese traditional group of murder. And our country is not a gun society, but they have. And they also have a nice and beautiful tattoo in the whole body. And why I picked up these figures is that our hospital is very kind for them because I did the surgery for this guy. I performed the posterior lumbar interbody fusion, and the dragon's face was nicely repaired with great future by me. So he's very satisfied with my surgical procedure. So anyway, my talk is not Yakuza, but laminoplasty. So, there are 2 represented with laminoplasty procedures. One is open door laminoplasty, which was established by Dr. Kirabayashi, who graduated from the same Keio University. And the double door laminoplasty is established by Dr. Furukawa. He was graduated from University of Tokyo, as Dr. Oshima did. So, Recently, we conducted a prospective mark center study to compare the results between the open and double door laminoplasties for OPLL, and the results demonstrated comparable recovery or ratio in JOA score, JOA CMEC, or rate of complication. However, there remain some concerns about the complication after laminoplasty, such as laminar closure, segmental paralysis, such as cephal palsy, or axial pain. So Dr. Matsumoto, our boss, previously reported the surgical outcome in patients who underwent the laminar closure and demonstrated that the laminar closure occurred 3 months after the surgical procedure and maintained over time. In terms of segmental motor paralysis, the cause of this cephal palsy is considered to be excessive posterior shift of spinal cord with high intensity zone articulated image. We previously reported that the cause of the cephal palsy is due to excessive laminar open angle with the plate anterior to the spinal cord. So we use laminar plate to prevent both laminar closure and excessive posterior shift of the spinal cord. So this is the post-surgical X-ray. We put the laminar plate at C4 and C6. And then we performed the we performed a study to compare the surgical outcomes between the plate group and the suture-only group, which was previously performed. The results show that there's no significant difference between the suture and plate group in operating time, blood loss, or JOA score recovery rate. But the plate group shows significantly less open angle compared to the suture group. So our results demonstrated that the laminar plates suppress the excessive opening lamina and the excessive posterior shift of spinal cord. So these results, our data resulted in the reduction of incidence of cephal palsy. Here's the data, and as you can see here, there's significant reduction in cephal palsy in plate group compared to the suture group. So now we always use this plate to reduce the complication of cephal palsy. So here's another story about the cephal palsy. We evaluated the results of impact of diabetics for OPL patients. And before starting this study, we made an Asian Pacific spine study group to make the huge database regarding OPL. Because, OPL prevails in Asian countries, so it is very significant and meaningful. And when compare the surgical outcomes after laminoplasty between the diabetic and non-diabetic patients, surprisingly, the ratio of cephal palsy is significantly higher in the diabetic group compared to the non-diabetic. So why did cephal palsy occur in diabetic patients? Pathology of diabetic neuropathy is considered to be degeneration at the distal axonal terminal and axonal disruption of motor units at neuromuscular junctions. So after laminoplasty, posterior shift of the spinal cord is occurred, which resulted in the excessive traction for cephal nerve roots, and then the cephal palsy occurred, we believe. Here is another story about the complication after laminoplasty. We evaluated the impact of tobacco smoking on outcome after the posterior decompression surgery in CSM patient. Here's the background. Previous study demonstrated the impact of smoking on cervical surgical outcome, which resulted in increased surgical site infection, low fusion rate after fixation, or insufficient functional recovery. The problem is that the heterogeneous pathology and surgical technique more complicated, and there's no study to analyze the impact after laminoplasty. So we conducted a study to evaluate the surgical outcomes between the smoker and non-smokers, exact matching analysis. And the results show that the ratio of delirium is significantly higher in smoker group compared to the non-smoker group postoperatively. So why did the delirium occur in patients who smoke? Acute smoke cessation after
hospital admission provokes abstinence symptom by nicotine withdrawal. So abstinence symptoms show similar feature to delirium pathology, such as imbalance of neurotransmitter at synapse. So this relation has pointed out at other medical fields such as stroke, cardiac surgery, or psychiatric disease. So we believe that 4 to 8 weeks for tobacco cessation before surgery contribute to significant decrease of complications. And finally, I want to introduce the clinical indicators of surgical outcomes after laminoplasty for both CSM and OPLL. And we conducted a multivariate logistic regression analysis using a CMEC, and the results show that the recovery of bodily function and quality of life were hindered by pain and older age. So surgeons should pay attention to reduce the pain after the surgery, especially for elderly patients. So thank you very much for attention.
Morning. I'm Oshima from the University of Tokyo. Thank you very much for having us here so early in the morning. My talk, assigned talk on the advantage of minimally invasive spine surgery, but it's too big a topic for any talk. So I'd like to focus on scopic surgery today. And I'm Yasushi from the University of Tokyo on the I'm a chief of brain division in my institution. And more recently, 70% of the cases of cervical spine, only of 40% are MIS. This is my family, and we Yasushi. Now, you can see my kids' name, Hiroyasu and Toshiyasu. They are named. So when we need clinical research, we have a lot of databases. For example, we use a national inpatient database in Japan. Maybe I think it's like an NIS here. You have the same kind of database here. Well, we have established our own register recently. We also doing a cohort study, doing everything. But today I'm going to focus on the two registries. The first one is of National Inpatient Database in Japan. It's one of the real world data consisting of discharge abstract and administrative claim data in Japan. So all academic hospitals are obliged to participate. And it has many cases, over 7,000 cases per year. So it's very good in that we can collect a lot of cases. But the disadvantage is there are no patient-reported outcomes, or we cannot look at radiographic data, for example, or the details are unknown. We cannot see the surgical level or proposed. This database is very good. For example, we looked at whether the signal variation is the risk of reoperation for SSI, selective spine surgery. So in this study, we collected 47,000 patients, and the reoperation rate for SSI was about 1%. So which do you think? Which month do you think is highest? Answer was, the lowest in February, and I think New Year's start April in Japan. By the way, the August was the second highest. In the right study, we look up the mortality or morbidity among people over 19 years old. So we could find 408 patients of 18 years old or more, and the 19-day mortality was higher. It's 1.4%. So they are at high risk. By the way, there are mainly three kinds of endoscopic surgery. One is the so-called microendoscopic surgery using a tubular interrupter with a scope inside. This one is so-called a full endoscopic surgery. It's a one portal technique, so very useful for disectomy. And recently, this is becoming popular among countries in all of European countries. This is a two-portal like a knee arthroscopic surgery under the water irrigation. So I haven't just started yet. But this is very good. For example, this is the case of L5 for partial laminectomy. And this is cranial, cauda, lateral. On picture, you can see the dural matter here. I'll show you a video. Because there is no room in the spine, so we have to coagulate to remove the soft tissue to reach lamina. This, when we're looking around here, this is lamina. So, and during it's not good. There are many bubbles, but anyway, we have to make lamina. Finally, we reach the yellow ligaments here. Now we're taking out the lamina. This is the dural. There is another around here. The best merit of this, if you can do both maybe method, I think I'm sure this will work in near future. I think about topic because regardless of there's my surgeon. Okay, so my question is endoscopic laminectomy less invasive than open laminectomy? It's a very simple question, but how do you approach this topic? First, we study using the National Impatient Database. So in this study, we could collect over 1,500 cases in each. And as a result, in the endoscopic group, the major complications or things like delivery, they are the less. So, but we did not know whether patient or outcome were also better or not, or any other surgical or related complications. So then we use this registry of our own. We established a non-profit organization called UTSD. This of 20 high volume center and 4,000 cases per year. Using this data, we again look at whether endoscopic surgery less invasive or not. We collected 249 patients only with L5 decompression. We have rather homogeneous population. And as a result, the MAEL means laminectomy, microendoscopic laminectomy. The surgical time was less with less one or not. When we look at the patient reported outcome, they were almost the same. So, but the satisfaction rate was better in MAEL group. So taken together, the result of the national data. This is the result of our own data. There are good points and bad points in each study. But my question was scopic, like this invasive, and I think my answer is so using kind of data. We have published several reports every year, and this might mainly sponsored more sponsored users. We have only studied studied. Yeah, we're looking with it. The in the AI, so that we can live more. And looking at the dynamic mobile wearable system, motion capture is these are large space. While we got brain or like a biology ever. Finally, if we can still stay in Japan today, ninja, samurai, geisha, small restaurant. Because one of my friends in the United States asked me, is your grandpa ninja? Actually, they have no ninja or no samurai. So we can see from geisha in Kyoto. We can see many small restaurants. So, okay. Any young the next month. Okay. Thank you very much. We are going to have hold a day meeting. Okay, 3 years later. So if you have a chance to come and join us, thank you very much.
Thank you for having us today. I'm going to talk about blood supply in the flock. I'm Ichiro Tonogai from Takamatsu Red Cross Hospital in Kagawa. This is a major baseball player, Ichiro. My name is Ichiro, and his name is the same as me, so please call me Ichiro. I'm not a good at playing baseball. And when I was medical student, I was playing tennis. I was a leader fellow of the foot and ankle department from 2015 to 2016 in a hospital for special surgery HDS in Manhattan. Now I'm working for Takamatsu Red Cross Hospital in Keio. This is a map of Japan. Here is Tokyo, and there is Osaka to Kyoto. So Kawa is here. This is Kawa Prefecture, Shikoku. And Kawa is located in the northeast of Shikoku, one of the four mainland. About 1 million people living in Kagawa Prefecture. It is the most smallest prefecture in Japan. Takamatsu are living in a chapter in Kagawa. Do you know udon? Udon noodle is the most famous local food in Kagawa. There are over 700 udon restaurants in Kagawa. It's common to boil udon noodle in a bowl and add warm soup to it. So these are my kids, 7 years, 5 years, and 3 years old. The Kazuki, Takashi, and Yuri. So it's a bit later, so I often go to the restaurant for holidays. For us, no don, no right. So these are the lines today. Metatarsalostomy are useful to treat Haruka's burrows, metatarsalgia, empty subluxation, dislocation, and burnout. Like it figure. But a complication like non-union, red union after metatarsal osteotomy may be related to a disruption of nutrient artery supplying the metatarsal. So we investigate nutrient artery point into the metatarsal using enhanced CT image of first cannabis. This is a nutrient artery into a first metatarsal. As a result, distance from metatarsal design or proximal to a nutrient artery into the first metatarsal is 22 or 33 millimeter. All nutrient arteries enter the first metatarsal obliquely from a proximal direction. In 87%, the nutrient artery entry point is a distal third or junction of a middle third and distal third. As regarding for second to fourth metatarsal, distances from the metatarsal distal end to nutrient arteries entry points is the second, third, and fourth metatarsal is 46, 41, and 39 millimeter respectively. And then distance from the metatarsal proximal end to the nutrient arteries entry point into the second, third, and fourth metatarsal is 23, 25, and 25 millimeter respectively. The nutrient artery entry point are middle third of second, third, and fourth metatarsal in 63, 81, and 81% respectively. This is the entry into a fifth metatarsal. Distance from the metatarsal distal end or lateral proximal end or medial proximal end to a nutrient artery entry point into fifth metatarsal is 42, 23, or 15 millimeter respectively. All nutrient arteries enter the fifth metatarsal from a distal direction. The nutrient artery entry point is around the junction of middle third and proximal third. Being careful about disease supply when treating heart struggles, we perform osteotomy take-film procedure. That is a Tonogai procedure. There are complications such as Haruka's virus. Main purpose of this procedure is to avoid Haruka's failure, because it is difficult to treat Haruka's failures. So it's named by temporary KY fixation of the first metatarsal joint take-in method. After osteotomy, KY serves as a landmark. We can know how much is the first toe and the distal fragment are corrected using KY as a joystick. Finally, fragments were fixed with screws. There are some technical tips in this procedure. Transfer cut from the plantar medial direction is important. Then a distal fragment is spinated and shifted to plantar direction. Plotting of distal end of proximal development is also important as well. First and second metatarsal longitudinal axes should be parallel. I will show you a short print outcome of this procedure. 34 feet were treated with this procedure. Average follow-up duration is 28 months. So ATVA improved from 44 degrees before surgery to 8 degrees after surgery. MOM angle improves from 17 to 4 degrees. Clinical scale like Japanese Society for Surgery of Foot JSFF scale improves from 45 to 85, 84 points. Although there are a few complications such as helps insufficient flexion, but I believe this is one of the useful features for Hux data. When we perform osteotomy at more proximal level, we should be careful about the plantar arch. It crosses a plantar plate of transverse. According to our study, this is the plantar arch. And the resistance from second, third, and fourth metatarsal proximal end to the plantar arch were 23, 21, and 8 millimeters, respectively. The plantar arch runs the proximal cell level. So when we use a short or proximal osteotomy for about 45 to 47 millimeter proximal to the distal epiphysis, or it could interrupt blood supply in the plantar arch. Moreover, we perform osteotomy at more proximal level. We should be careful about dorsal pedis at DPA. DPA runs into the space between first and second metatarsal. Accurate artery crosses second and fourth metatarsal base transversely this way, and it gives off from second to fourth dorsal metatarsal arteries. According to our study, in rows 37% DPA plot is standard pattern. Besides this standard pattern, there are few DPA patterns like this. So in this shows standard DPA course that anatomy textbook is showing is not observed so often. These are home take message. Thanks for attention. That's a very important question. We developed in a both system. First, we developed the smartphone system, and after that, we developed the VR goggles system. But we stopped developing. We stopped developing. We stopped developing the VR goggles as well. Because some surgeon are working for the music VR go on because
they feel it is or we are about Europe. And one of the advantage is low cost. So all present in the one time and there was but we must have by you are working on the smartphone system fine. Thank you.
Another question for Dr. Fujii, but Dr. North. Should his wife be doing TAOs instead of PAOs? And should Dr. North's wife does PAOs? Should she be doing TAO? Would you Is she visit you guys and learn how to do that? All right. Yeah, but that's the area. No. But basically, I think I'm close to 800 at your institution over, like our plane. About 20 years, but when you do that many procedures over that like time, you learn a lot of new things. Literally adapted what you learned for procedure they hadn't seen before, and the results seem, phenomenal. I think your patient population may be a little bit different. The average BMI was about 22. So, but do you think that this is something that's going to get adapted internationally, or do you think this is going to stay local at your institution?
There are several types of in Japan. I applied for right now. There was so at the same week. So I think all patients are stepping which it is with actual but the bank joke and there us yeah, thank you. That was all bucks. It's sort of like TAO. With the PAOs, the vascularity of that freeze rag studied and looks like once those fragments actually covered, so for us, this doesn't need replacement. A TAO and then a one allograft probably never was fully revascularized. Do you have a long enough follow up to know how to replace TAOs with allograft? the TAO there.
Yeah, but for many of us, eventually, every place. I'm just wondering how those two given. Yeah, well, I guess an easier question is studying the vascularity of random easily. Placements doing those patients who eventually undergo replacement.
And there were no, still no necrosis of the
Is it more challenging to do a total part of the blessing in the setting of a TAO? I think that's what Dr. Chance used. Just talking about it's probably some early longevity to know. Yes. It's getting out of because you're angry. One that's transient. It's what grace and also bog down ground. But another good question is it there? Another question that Dr. Miller had for Dr. Nagoshi. Do you make your surgeon, do you make your patient that smoke before you do a cervical laminoplasty? Do you make your patient stop smoking 4 to 6 weeks before surgery? And if so, how do you do that?
Yeah, after publishing the paper, I advised the patient to that, but I'm not sure precisely whether they stop smoking. But the ratio of the uranium is very low. So I usually cannot notice whether the patient has but I usually say the patient stop it. Period. But the question I have for you is after you added plane to your practice,
Any differences in infection rates or about the same?
Yeah, it's the same. Infection rate is very low because the plate is just small, so it's not, it doesn't matter. Thank you.
Any other questions from the audience?
About the other topic. Let me know. How did you develop your skills and what was your progression skills doing in a life? Yeah. Do a lot of camera work first, and how do you train others? To make so this is around I'm going to do something
Others, the largest company, the same as Galway. Seems like all your parameters were improved within the company techniques with the one exception of girl terrors. And did you follow with time your incidents of dural tears? In other words, is that just a part of the procedure, or did it turn out it was experience related as a or experience with the rate of dural tears? Okay.
I thought we had really interesting. For example, also, if you do all your care, but things is I used to about recent in that just did it talking to the your mother with the people you do to that mostly with I'm not sure about the soft tissues on one blood. I think that's the reason why
Great. Well, thanks a lot. I really enjoyed your talk.
we just
Thanks. Thank you. Thank you.